Am I audible? Yeah. Good morning, everyone. I would like to thank AIOC for giving me this opportunity and Harshvardhan for inviting me for this instruction course. Now, the previous speakers have clearly explained that the difference between PRK, is mechanical removal in PRK, whereas the laser removes the epithelium in trans-PRK. Now, my experience is limited to using the Schwinn-Amaris, which we have at our center, and I can say that the advent of this machine has revolutionized the surface ablation procedure. Now, what are some of these features? It's got an extremely fast pulse rate. In fact, here I've mentioned 500 hertz, but the newer machines have 750 and 1050. So it takes hardly 2 seconds per diopter in myopia. Then it has got an amazing 5D tracking system which prevents decentered ablations and accounts for cyclotorsion. It has an asymmetric offset. What I mean by this is when the laser fires, it takes the corneal vertex as the optical axis of the ablation, and the higher order aberrations are treated to the pupil center. So this prevents certain kind of higher order aberrations like an coma aberration from defocus correction or a trefoil aberration from astigmatism correction. Other salient features are like intelligent thermal effect control and automatic fluence level adjustment. Now, this is a small video which just shows almost what is happening. So that in the Schwinn-Amaris, it's an extremely versatile machine where they say that the epithelium removal is actually refractive neutral, and they have different ablation rates for removing the epithelium and the stroma. And one of the reasons why it works well is that it leaves the surface very smooth and is an excellent tool in doing a lot of things on the surface, like when you're dealing with irregular corneas, as the previous question was directed to, or when you're dealing with borderline thickness cases. So as I said, the ablation profile consideration, it is a refractive neutral for the epithelium removal and has different ablation rates for the epithelium and the stroma. It makes an assumption that the epithelial thickness is 55 micron in the center and 65 in the periphery. But with the upgrades which have come, you can actually, enter the epithelial thickness, though the company says that you did not change it. So you can actually do an epithelium map on the spectral domain OCT and try and titrate it. But because they claim it to be a refractive neutral procedure, they really don't advocate it. Now, what are the advantages? It's obvious that it becomes simpler, quicker, lesser pain, lower grade of haze, and a faster reepithelialization. Now, with the advent of the smart surface treatment, basically in smart surface, it makes an assumption that the cornea is not a flat surface, but it akins it to a Fullerene structure. Now, what it does is it leaves the cornea smoother post the procedure. So here you have two images, which are, one is post a without the smart pulse, and the other is with the smart pulse, and you can see that in this electron microscopy picture that the surface appears smoother. It also reduces the roughness by around 60%. Now, what does this mean? In one of the studies where they looked at around 50 patients and divided them in two groups, where you had the classical trans-PRK and then the smart surface group, they looked at the day of epithelialization, the uncorrected distance visual acuity on the day of epithelialization, and the pain score. Now, whenever we talk about surface ablation, one of the biggest hindrances to, is the people say that there's no wow factor, the amount of pain that the patient experiences, the uncorrected distant visual acuity takes time to settle in. Now, with the next few slides, I'll try to debunk some of these myths. Now, here you can see that almost like the day of reepithelialization is the second or third day in most of the cases, though it actually depends on the amount of diopter that you're treating, and the uncorrected distant visual acuity actually is much better. In this multicentric study, which covered around 1,000 eye across 8 centers, they have shown that up to 30 minutes after ablation, if you take the patient and make him sit and see the Snellens, almost 65% of the patients have an undistant visual acuity of 20/40 or better. And this is not bluffing. I mean, this is something which I regularly do in my practice. We make it a point to show to the patient that you've already improved. And this takes away some of the inhibition when we talk about surface ablation, that there is no wow factor to it. 90% of these eyes achieve 20/50 or better at day 1. So my first point is, please take away this that the uncorrected distal vision acuity is not good at the first day. The second is the efficacy. Even at 1 month post-operatively, the efficacy is excellent. 84% of the eyes had less than 0.5 diopter of astigmatism in this particular study. So now let's look at some of the concerns. Corneal haze is something which everyone talks about. Wherever I speak, and people always say, nahi yaar, corneal haze hai, and when you're dealing with high diopters, it's a big issue. Now, if you look at corneal haze, you have early corneal haze and late. I won't go into the details of this, but there was a beautiful paper from the Narayana group which got published in IJO, and where they did a retrospective study and tried to kind of come up with a risk score for trying to see whether looking at a patient preoperatively, can you actually look out for which are the patients who are likely to develop corneal haze and kind of segregate them. Now, this is what they did. They looked at contact lens intolerance, TBUT, gland dropout, OSDI scoring, vitamin D levels, and the working environment. And they gave some scores to this, and they divided these patients into 3 groups: low risk, moderate risk, and high risk. Now, please look at the next slide. Only 1 out of 235 eyes in the low risk group developed any kind of haze, which is 0.4%. So if you are very good with your pre-op screening, this concern about haze is actually not there. Even in the high risk group in their particular study, 4 out of 88 eyes developed a bit of corneal haze. Now, what about us? We have, till my last data was collated, it was around 491 patients, both eyes were 514 patients with 982 eyes, or 1005 eyes treated. And we have treated around 20 patients in the -8 or plus group. Only 1 patient developed some kind of haze which was persisting at around 3 months, but again with treatment with loteprednol, cyclosporin, this reduced over a period of time, and the patient was never symptomatic, mind you. This haze was just something that I was noticing when I was seeing the patient. So corneal haze is an overhyped thing post-surface ablation. Some of the other data, this particular paper from Abid Mogaddam et al., which looked at high myopia. This thing comes across above 5, it is no longer a safe procedure. So they looked at -6 to 8.75. And in this particular also, they had just 1 patient with trace and another eye with grade 1 haze. So there is enough data to say that corneal haze, especially with a platform like the Schwinn Amaris, is hardly an issue. It's not an issue. And if you look at plan your pre-op screening, which carefully, you're not going to face this. Now, what do? We look out for a history of chronic allergic eye disease and keloid formation. These patients, you got to be a little careful. Please do your OSDI scoring. Look for mebomitis. If you have any underlying chronic allergic disease, treat it with an antihistaminic. Start the patients with calciferol if the vitamin D3 levels are low. Look at the OSDI scores. If you find that the lid margins are inflamed, start a patient on doxycycline along with azithral. So if you are a little patient, and if you're not just concerned about losing the patient because you're going to set up some time before you take the patient for the procedure, I can assure you that you're not going to see any post-op corneal haze if you've been careful with these things. Intraoperatively, smart surface treatment, I think, is revolutionary, and that's the greatest, I think, technology advancement that has occurred. Using mitomycin C with a 0.02% concentration, and I do it for every diopter, we do it for 10 seconds up to 60 seconds. Post-surgery, topical steroid, whether you start on day 1 or you start later, has been a little controversial, and I have veered between 2. Concerns about infection initially made me look at it, but right now we start with the loteprednol right from day 1. We keep the patient on vitamin C for a month. Calciol, 1 sachet with milk once a week for 4 weeks. And again, if the patient had any pre-existing issues, like an poor OSDI score, we look into that. Another thing that we are very particular is talking to the patient about their lifestyle. Mind you, UV light exposure, especially when the patient goes out in the open. Let's say the patient has an active outdoor life and he's going out for walks or runs in the morning, then you're going to get a little bit of haze. So we are particular to look at this and instruct the patient accordingly. Now, we've talked about the safety, the haze part. Now, what about efficacy? This is another thing that comes in. LASIK is much more efficient. Femto-LASIK is wow. SMILE is the best procedure that could have been there. But let's look at data. This meta-analysis, which looked at 1924 eyes, actually showed the efficacy was around 94%. And if you compare results, if you look at this particular study, which looked at 85 eyes and in almost roughly 80 in each group between femto and the TRANSPRK, the uncorrected distant visual acuity was almost equal in both the groups. And in fact, at 1 year, the refractive predictability was found to be higher in TRANSPRK compared to the femtolasic group. So, there are papers which would say something otherwise also. Now, here we are not out to compare two procedures. What we are here to say is that TRANSPRK has excellent efficacy and gives excellent visual outcomes. Even when you compare it with SMILE, you will find that the data suggests that refractive power is similar post-TRANSPRK and SMILE, and that the uncorrected visual acuity, there's no significant difference between the two procedures. Now, astigmatism. Now, again, my initial concerns when I migrated from lamellar procedures to surface ablation was, would I get accurate corrections for astigmatism? Now, look at the data out here. In one of the studies by Z et al., which used vectorial analysis to look at the SIAs, they found that 100% had an uncorrected distant visual acuity of 20 or 20 better, and residual cylinder was less than 0.5 diopter in more than 93.6% of the cases. So it goes on to show that even in astigmatism, it is an excellent tool. When you compare it with SMILE, in fact, I would say TRANSPRK stands better because here you have an option of looking at cyclotorsion because of the amazing 5D tracker on the Schwind Amaris. Whereas when you're doing SMILE, because there's a docking system and you have to do a mechanical marking of the axis, the amount of astigmatism correction, if at all, is slightly better with TRANSPRK. What do? I actually go onto the Alpine's calculator online and I look out for what I call the they have a nice nomogram for the ocular residual astigmatism, and I feed the data into this calculator online. And at times, if I feel like on the TRANSPRK, on our machine, you have an aberration-free mode and a corneal wavefront guided mode. Normally, 95% of the time, you need an aberration-free. But if I'm dealing with astigmatism, I would go on to this particular calculator and then use this to decide my final treatment. So like if you see out here, you will see that the corneal power out here was 42.5 and 45.5. The refraction was -3 with -2.5. So they have an option where you can treat 60% refractive and 40% corneal. So the intended treatment changes. Now I have found this to become a very useful tool when I'm dealing with astigmatism, and I tend to get much better corrections after I've adopted this in my practice. So whenever the ocular residual astigmatism is more than 1, I use a ORA calculator. You have to go to assort.com. It's freely available. And then I use the 60-40, whereas 60% is refractive, 40% is corneal, and I do accordingly. Now what are my applications? Whenever I'm dealing with a thin cornea, which seems to be very common in our patient population, you quite often have situations where a patient has a 470, 480 corneal thickness, where you aren't quite sure that you cannot do a lamellar procedure. In these kind of patients, then this becomes a great tool. Now, sometimes, you have patients coming to you with a Corvisca reading, which shows that the biomechanical stability post, is not, the biomechanical strength of the cornea is not that great. But data from Narayan Netralaya, where they have done polarized anterior segment OCT studies, and they've compared the corneas post-TRANSPRK, post-lamellar procedures, collagen cross-linking, and they've found that the cornea seems to be, in fact, a little bit, it's quite stiff and strong after a TRANSPRK procedures. And that has enabled me to do a lot of TRANSPRKs in a borderline situation. So when we have the ectasia risk score and where you are in the moderate risk zone, I land up doing a surface ablation. So these are like those examples where you have a thinner cornea. When you're dealing with corneal opacifications, it's an amazing tool, very versatile. PRK extra, so sometimes when you're dealing with keratoconus patients and you have a good corneal thickness and you want to kind of give the patient a better refractive outcome, you can actually first ablate the cornea and then land up doing the collagen cross-linking. When you have flap complications post-lamellar procedures, again it helps you and it's a very versatile machine. Now I just wanted to close by saying that not all is rosy. We went back to do a little bit of an analysis of our patient satisfaction, because one of the concerns in private practice is am I overdoing a procedure and am I missing something out there? Am I not smelling the coffee proper? So what we found that the pain factor was around, it wasn't as great as the studies were saying. There were patients complaining of pain, and commonest were in the, they graded pain on the scale of 5 to 10. However, when, they are explained that when you're doing a lamellar procedure, there are certain flap complications that can happen versus a slower recovery. Almost, they said that 87% said that they would recommend this procedure to their friends, given the fact that it is safe. And generally, what we are doing now is trying to do an analysis at 1 week and later at 1 month. So what we find that what a person feels at the end of 1 week versus what he feels at the end of 1 month changes. And once they start seeing the difference in vision, they are more happy. So I would like to conclude saying that it's an extremely safe and effective procedure. I do it where LASIK is clearly contraindicated. Steep corneas, flat corneas, when you see hot spots on topo where you're scared that, if the keratom goes through, you might have flap complications. Thank you for your patient hearing. Thank you.
Thank you, Chinmay, for a